Welcome to Heart Failure Unfiltered. My name is Nick Hartshorn-Evans and I'm the founder and CEO of the Pumping Marvellous Foundation, the UK's heart failure charity. Today, we will be discussing learnings from our Marvellous Masterclass events where we educated and worked with over 170 non-specialists to increase their awareness, upskill their knowledge specific to heart failure in primary care. This is the third episode of a series of 4 podcasts about heart failure and why the simplest ideas often save the most lives. This podcast asks one question over and over again. Heart failure in primary care, the moments that matter to the patient living with heart failure. Because if we don't enable our workforce to be better at detecting the symptoms, diagnosing and managing heart failure, this has a direct impact on patients. If you've just been diagnosed with heart failure, it can feel overwhelming. You may have more questions than answers. The Pumping Marvellous Foundation helps people make sense of heart failure with clear, patient-friendly information and supportive resources designed by patients themselves. Understanding your condition is the first step towards living with it. Search Pumping Marvellous Foundation and start your journey with the support you deserve. When I was diagnosed with heart failure, what I needed most was clear information and reassurance. That's why we created the Pumping Marvellous Foundation. Every day, we help people understand their condition and feel less alone. Just £5 can help us reach the next patient who needs that support. £5 may not change your day, but it could change somebody else's. Visit pumpingmarvellous.org and help support patients today. So today, guess what? We're at the Liverpool podcast studios where we base our Heart Failure Unfiltered podcast. We've got some amazing guests. So we'll start person closest to me first. Gav.
I'm Gav. I was diagnosed with heart failure at 55 and I've been through all stages now. I'm 2 years post-heart transplant and I'm a patient educator with the Pumping Marvellous Foundation.
Hi, I'm Dr. Sue Kemsley, GP in Cheshire, GPSI in cardiology, and I work as a clinical lead for Health Innovation North West Coast and for the North West Coast Cardiac Network.
Corinne.
Hi, I'm Corinne and I've been a patient educator with Pumping Marvellous for I think it's 4 years now. I was diagnosed 5 years ago with heart failure and I'm also on the board of trustees.
Great. So we've got some real experts in the room today. So this definitely hits home for me because I absolutely believe this, but why does primary care often shape the patient's entire experience of living with heart failure? Corinne?
I think unfortunately, if it's not done well in the first place, if people's diagnosis isn't picked up early in the first place, and they are, for whatever reason, not diagnosed quickly enough, they're not believed, it's something else, and if that goes on and on, unfortunately, they can then build up a negativity towards primary care, and then when they if they've then diagnosed maybe in a hospital setting and then they go back into primary care, that trust in the primary care, unfortunately, sometimes needs to be built back again. It can feel scary for people to go back to the place where their diagnosis was missed in the first place and they didn't feel that the people there had the knowledge. It sometimes needs that building back again.
We do hear from the community, don't we, that one of the most scary points is when they get discharged from their specialist and they get discharged back into primary care.
Yeah.
And it's a bit like a push off the cliff, really.
Yeah.
Gav, what are your thoughts?
Yeah, definitely. If you've been hospitalised, either because you just decompensated so quickly that there was no alternative, you had to go into hospital. When you arrive back in primary care, it's making sure that you feel that level of support is going to be appropriate to your needs. So it's making sure that you've got a good baseline assessment when you get back into primary care. People understand where you are. And I've said it in previous podcasts about making sure that there is a care plan in place for your heart failure. So everybody is agreed and knows which direction you're going to be going in. You're likely to be accessing specialist care, but that might be every 3 months, every 6 months. You don't know what level of support you're going to get. So the GP surgery, primary care, is going to be your first point of contact in most issues, any kind of issue that you have with your heart failure.
So, Gav, do you think that, the Marvellous Masterclass events that you went to in Preston and Everton, how do you think that the non-heart failure specialists took on your story? What do you think they did with it?
I think that when you related your experience, and mine was around misdiagnosis, but then the support that I got post-diagnosis, I think it struck a chord with them that it was obvious that there was a lack of awareness of heart failure, what the symptoms were, what the key symptoms are, and how quickly and how easily it could have been tested for using NT-Pro, BMP, etc. I think it was blatantly obvious that there were people that didn't know what heart failure was, that wouldn't be able to give a clear definition. But once they heard not just my story, but Corinne's and Katie's and others, that they understand what happens at diagnosis and how quickly things can go wrong, but how quickly you can recover it if you get people back into the right systems and processes, and the role that primary care has to play in heart failure in your journey.
I think also, seeing us, and we are positive people, we generally sort of want to make the best out of the situation that we're in now. But also when we were talking about our stories, you could see people's raw emotion. You could tell that it hurt us or whatever at the time, and it mattered to us. So
So from a GP perspective, Sue, heart failure, just to utter the words, you have heart failure. How important are empathy and communication during that diagnosis?
You're absolutely vital. It's a scary diagnosis, isn't it? If we're not able to articulate what it is confidently, and start to address some of that fear, then it remains the elephant in the room that's never dealt with. And that's not a good foundation for a working relationship with a patient.
So why is primary care uniquely placed to support people living with their heart failure?
Well, both, before the diagnosis and even prior to that, when people are at risk of developing heart failure, we have those patients all the time. We've got those patients for life. And we have multiple opportunities to see and educate people. I think, with people with long-term conditions, we commonly tell them, patients with hypertension or high cholesterol or who smoke, we tell them they've got an increased risk of coronary artery disease. How often do we tell them they've got a risk of developing heart failure? So we've got opportunities to educate people even while they're at high risk. We probably I'm absolutely sure we're seeing them when they've got early symptoms, vague symptoms quite often, but we've got opportunity to bring people back and review and recheck. And then once people are diagnosed, we've still got them for life. We can still, if things have gone a bit wrong, we can still try and get that back on track.
And build back.
And get that relationship back. And 80% of people are diagnosed in hospital currently. There are some that are always going to be diagnosed in hospital with acute heart failure with no apparent warning. And, there will be some. And those ones are probably even more vital to gain a relationship afterwards, because you've not seen them during that episode at all. So I think we've just got that ability to have the lifelong working relationship with a patient.
So we talk a lot about diagnosis and primary care's responsibility. I don't know whether that's the right word, but what primary care could do really well in kickstarting that diagnostic process. But what's the biggest thing, Sue, after a diagnosis, when they come back to you, they're discharged back to your GP surgery, to your primary care centre? What's the biggest thing you think from a clinical perspective? Because I'm going to ask Gav and Corinne from a patient perspective, but from a clinical perspective, what do you want to tell people out there that's the most important thing that they can do?
Not to stop their medication. It's definitely one of them.
Right.
I think there's two parts to that. So the first part is it's not always clear when someone's discharged.
Right.
Because sometimes they tick along on an outpatient list and it appears that they're being monitored and looked after, and they're not. And communication's not always good.
They're just on a list.
They're on a list. And we don't always know what's happening. So there's one part to it. So it's not often a clear line in the sand of somebody being discharged. I think if somebody's had a hospital admission with heart failure, that's a clear line in the sand, isn't it? They've been discharged from that admission. And I would say it's really important to review that patient and see where they are, what's their follow-up, what's been happening. If a patient has truly been discharged from a heart failure service with plans for ongoing management in primary care, we absolutely need a good working relationship. But I would say you need that before they're discharged. So during that grey area period that I've just talked about, where somebody might have had their diagnosis, or sometimes part of their diagnosis, you know, they might have had an echo, they might have had not very good views and might need a cardiac MRI. It's all being sort of worked through. There might be a lot of uncertainty. I think that's really difficult for patients to handle. And we need a good working relationship with patients.
That must be exacerbated by the wait times as well for,
absolutely,
you know, you have an echo, but it takes
Really
quite a long time
difficult.
for people to come back to you who's interpreted it and say next steps are. And by that time, the patient's in
my area, my patients are waiting a year.
Wow. Ouch.
To see a heart failure specialist.
That's a new podcast.
So I can't not treat my patients. Obviously, I've got a different background, so I do, and that's easier for me than most GPs would be able to do. But during that interim period, we need to be able to manage and support and help and guide like we would for any condition. And we need the same once people are discharged.
So it's clarity
about what you're actually going to do.
And treat. Don't take them off the meds.
Absolutely. Yeah, I mean, you need all of the... It's
going to attack you in a minute.
It's in the way, really. We'd need a podcast on an effective long-term condition review for heart failure. You need a structured approach. People need to know, they want to know times, they need to know when they're going to have to do things, what they're going to have to do, what blood tests to do. People often wonder about when do they need another heart scan, and when will they see a specialist again. You know, all of those. I think we need to allow people to ask the questions that they need to ask, and it will differ from patient to patient.
So a care plan.
Oh yeah, absolutely. Thank you for saying that for me.
I think, the feedback I get around care plans, and it is in the NICE guideline, it's been in the NICE guideline since 2018, is not another care plan.
I know, yeah. That can be true.
And is that because we just process, it's like, what was it the police say that, listen on the news, like they're spending more time doing the paperwork than catching the criminals, yeah? I mean, are we spending more time doing the paperwork than actually treating the patients? I don't know. But that was the attitude that I got. And it was just an honest appraisal of, another care plan.
So I think a care plan is of no use if it's a paper document that someone's going to just chuck in the bin and or lose, or the dog's going to eat. I think what's really important is not the plan itself, but the process and the discussion. I think you do need, you need robust call and recall systems in primary care. We have to empower patients to come for their appointments and come for blood tests and come for reviews, but not everybody does. So we do need effective recall systems and all the support care coordination working in the background. So it's not just that GP appointment.
Every day, someone in the UK hears the words, "You have heart failure." For many, it's confusing and overwhelming. The Pumping Marvellous Foundation helps people understand their condition, find reassurance and connect with others who truly understand. Your donation helps us to reach the next patient who needs that support. If you'd like to help, please visit pumpingmarvellous.org and consider making a small donation. Together, we can make sure no patient faces heart failure alone.
Just turn that conversation around on its head. Corinne, the question to you now, what makes the biggest difference after diagnosis, and why is primary care uniquely placed to support people living with heart failure? What is it? What's the nugget for you? What do you want to give to the listeners today?
I mean, I was thinking about what you were saying about the care plan. So it's not necessarily, as you say, not the piece of paper or the making it onerous or whatever. It's saying to the patient when they've come in for that appointment, for whatever that appointment is, right, I'd like you to make another appointment in 2 months' time. I want to see you then. And so they leave that appointment feeling like they know what the next step is, they know where the next stepping stone is, or 1 week time, or whatever it is, or and I think that helps. Just knowing not necessarily a whole year's worth, but just the next bit. Okay, right, and feeling like you're part of that team. And it's also the whoever it is, the GP, the nurse, or whoever it is that you're seeing. Understanding you and what your heart failure is like, what your good day looks like, what your bad day looks like, knowing that one person's heart failure and what they struggle with the most isn't necessarily the same issue as somebody else's as well, and that healthcare professional knowing that. So when you come through the door as a patient and they say to you, come on then, tell me what's been going on, and how are you finding your low blood pressure at the moment? Is that still causing you issue, or is it? And it's so you feel like they understand you, which would be great. I mean, I know it's a magic wand. I appreciate that, but yeah.
I think it's small steps, isn't it?
Yeah, exactly.
It doesn't have to be everything every single time.
Not at all. Yeah.
But and sometimes I get told off for writing everything down for people. I sometimes say, "Do you want me to write it down, or can I text it you?" And they say, "Oh no, I remember." Well,
yeah.
I get accused of suggesting that memory is not very good.
But I think
everyone forgets when they.
Oh yeah, exactly. And there's lots of things, but you even if it's just one little nugget,
little things
that feels like you're connected in some way, and that person has got your back, and that you feel like they're looking out for you for your whatever it is. That would be good.
What's the nugget then, Gav? What can you?
I mean, I think in primary care, there's lots of things that will happen between you seeing a specialist. So you'll see your GP, or you'll see the nurse, whoever you're seeing, and it will be a GP if you're going to change a medication, or you're going to change a dosage of a medication. And it's almost preparing that patient for what might happen. We're going to increase this piece, we're going to change this, we're going to add this. What you might experience is this, or this. However, don't worry, because it's quite normal initially, but hopefully we would see an improvement on that. We would see that recover after a period of time. Whenever you introduce a new medication, whenever you change your regime, and agreeing with the patient, giving them the right information. So using some of the amazing Pumping Marvellous information that's out there, saying, if you take this away with you, you might forget what we've just discussed, but this will give you the knowledge to look at in a few days, but understand what might happen, but agree that if this happens and it gets to this critical level, you need to contact us. So whoever we see as a patient, when we go back into primary care, they have to have that skill and knowledge, ability and confidence to be able to communicate what might happen as a result of something being changed, and when they need to red flag that. So it's almost that we have the Marvellous symptom checker. So you've got the red, amber, green symptoms.
So do you think... So the masterclass was relatively prescriptive about what we felt from our insights as a team. And it was a very broad team, from patients to system leaders like you, Sue. But do you think that what we've just been talking about, do you think that was taken away by X amount of people from the events? Or do you think that's something that we could maybe develop a bit more? It's about confidence and...
I think we were trying to lay the foundations.
Sure.
And
Such a big topic, yeah.
It's a big topic, and I think, like we said, you have to start somewhere to kind of go everywhere with heart failure. I think, if you can't diagnose it, you can't treat it, can you? So I think the strongest emphasis we gave, I think, was on diagnosis. That was threaded throughout. And if anybody went out of that room without knowing BEAT and NT-proBNP, then they must have...
That was it.
had better earphones in the entire time. So I think that was, and as it should be, that was the focus. And then we started to sort of pad it out with some of the things that they need to start to learn and understand. So sometimes knowing what's out there first is a starter for 10. So they know that the 4 pillars, 2 pillars, foundation of cardiac rehab and all the rest of it now is out there and is something they should be thinking about. They know that a long-term condition review needs to include more detail on heart failure and that there's more that they need to do. I'm not sure we really drilled down into what that was. I think I've done teaching on what a good heart failure review looks like, and we didn't do that in the masterclass. And I think primary care particularly would benefit from that. Yeah.
I mean, there was some shocking figures. And I think what you've just done is nailed it, actually, that we were trying to cover all bases as a starter for 10.
It is, yeah.
That nobody, I'm not going to say which event it was, but nobody knew how to refer somebody for cardiac rehab.
No.
And the specialists think that cardiac rehab is as important as the medications. It's the 5th pillar. The 4 pillars are the medications.
I quite like the foundation. It was the foundation.
They
called
it
it
that.
I can't remember what you said there. It wasn't. But yeah, absolutely. In statistics like that, you need to drip feed. You can't just expect people to just pick this up. So, Corinne, what would happen if every clinician saw heart failure through the eyes of you?
Oh, wow. I think that we've talked about this, that you do end up sort of suspecting it of people that you see. So it's literally just thinking those symptoms constantly, the BEAT symptoms, the breathlessness, the exhaustion, the ankle swelling, but it's realizing that one person's breathlessness isn't the same as somebody else's. It's what their normal is. So my breathlessness, if you like, was that it was when I was running uphill, so I was still able to run. Some people can't walk. Some people can't walk to the other side of the room with their heart failure. So there's different starting points, if that makes sense, for different people, and it's understanding that. I think for my situation, my fitness level disguised mine, shall we say, and I still think it does to some extent still now. But it's no less, if that makes sense, an impact on me as it is to the next person. It's because of the starting point. So I think it's being aware of the symptoms, but putting them in the context of the person that's in front of you, and seeing them that way.
Gav?
Yeah.
Everybody has your eyes, Gav. What would they?
I think they would. I think it's thinking about like what impact is this having on your quality of life. So you can live. Once I got diagnosed and I was treated, and I got on the 4 pillars, and I got to a really good standard, and I was able to walk a marathon. So I got to that level. But to understand what it was like before I got diagnosed, the not being able to walk upstairs, not being able to sleep, laid flat, not being able to breathe, to feel like you were drowning when you laid down flat. I think if people felt some of those symptoms, it's one of the most scary symptoms I've ever had. Just feeling like as soon as you laid down, somebody was I was being waterboarded, for want of a better phrase. I think they would really understand why patients get so alarmed when they come in and they're wanting somebody to deal with it. The symptoms are so frightening and so overwhelming. It impacts everything that you do.
That's really powerful, that what you mentioned about, waterboarding.
Yeah.
I get that. Yeah. And Corinne, I was there. I was definitely there. I couldn't lie. I remember waking up in the middle of the night talking about green aliens. Now, you may think, okay, that guy's off his head. But actually it's true, because my daughter would say, yeah, he rose like from the dead. And I started yabbering on about green aliens because I was so fluid overloaded for such a long time that, and certainly I think there's something about the fear of uncontrolled breathlessness that even if you're sitting up in a chair and you're gasping for air.
Yeah.
I mean, for me, it would be, think heart failure if you see these symptoms, but also BEAT can be applied outside of the diagnostic context or outside the diagnosis context. It can also be you're living with it. So if you get more breathless, you get more exhausted, and your ankle's starting to swell a little bit more, time to speak to your GP or your practice nurse. And it's very much a contract. I've said this a couple of times, but it's a contract that, the NHS is very much perceived, I would say, as from, was it to grave? From cradle to grave. And we have to change that perception. It is there. And I get the arguments around we pay our taxes and all this, but it's a contract. It's something that is a win-win for both. Maybe I'm just babbling on.
No, I think you're right. I think that it is that shared responsibility for dealing with your condition. The NHS, be it primary, secondary care, whatever, is there to support you and to put in place the specialist tools. But when it comes to day-to-day living, you've got to play your part as well.
Yeah. And I think, you need to go with the right mindset to appointments as well. And if you go in there sort of, with a negative mindset, that's not going to come out well, is it, for anybody? But if you go in there with a positive mindset and a sort of an open mind, then it's, it's going to work.
I mean, I'm the sort of person who says, if you can teach somebody to win once, you can teach them again.
Yeah.
And if you can teach somebody to win self-managing and they get a little win, I think they apply that win to something else that they're not winning at, and they start moving forward with that and progressing.
It's time for a marvellous myth buster, busting the myths around heart failure. Myth: a diagnosis means you can't live a normal life.
Truth: many people with heart failure continue to enjoy meaningful and active lives with the right treatment, knowledge and support.
I just hope that what's come out of the masterclass is that this is an initial training and an initial awareness raising. There's more to come. But equally, don't expect to be turning up to one of those every 6 months or whatever to get the information. Take some responsibility as a clinician, and as we do as patients, to go out and educate ourselves and to understand a little bit more. If we've sparked that out, if it's awareness raising and we've sparked that interest, do what you can to go out and seek more information, empower yourself, talk to your senior colleagues or talk to whoever you need to do to influence the change to improve heart failure for patients.
So is the only
absolutely. Sorry, I'd absolutely agree with that. I think every little thing I've learned during my career, I've always wanted to share it. I don't know why. So maybe I love medicine. I love the subject. I love the science, and if I learn something, then I want everyone to be able to share in that. And I think if you when you teach something, you learn yourself. And if they've gone away, if people have attended the Heart Failure Masterclass have gone away and thought, so how do I start these 4 pillars then? They talked about it. I would hope that they'd be able to then go and explore it and read about it. We did give some links to resources they can have a read of, and there's obviously great national guidance and stuff. So I'd hope they'd be able to go and read, and that they could go and share, and that when they see patients with heart failure, they might start to think, oh yeah, we heard about that at the meeting. I'll just have a read about it. And
there was genuine passion and interest in the room, and it was you could feel the enthusiasm, sort of as as people were sort of learning different things or responding to things and asking really thoughtful questions and all those kind of things. It's great that and from my perspective, it was. I felt really happy because it's like these people are going to make it better, and that was really good.
Well, they'd all given up a day, hadn't they?
Exactly,
to
and
come,
there's people here who will walk out of here today, and they're going to make sure, hopefully, that it does improve. So it's fabulous. It's it's
So
it's
really
good.
So the big question is how do we scale it? Because I bet you there's other areas that would love to do something like this. And it's got to be digitally, really, hasn't it? And is that like a phrase, app, platform that's modularized into the presentations that we? I mean, you go through it, get you.
Yeah, I mean, different formats for different people, isn't there? And there's different formats for different topics as well, I think, because
But we can't
run a patient forum every week.
Yeah, we can't go all over the world, can we?
No, not really. I absolutely think recording, people...
If somebody paid us, then we'd probably go around the world, yeah?
Oh, yeah, I'll come with you.
But
to the hot countries.
But, we're doing this in the northwest. So South Cumbria, Lancashire, Cheshire, Mersey areas, which are huge populations, but there's also a lot of other population. I mean, the benefit from this.
There is, but then again, we do have one of the highest prevalences and mortality rates in the UK. Yeah. So I think that is as it should be. But yeah, it would be good to be able to share it.
That's something that we need to think about with the Health Innovation Network, I think. So on that note, thank you very much for attending yet again. A really deep, meaningful and thoughtful conversation. Thank you very much.
Thank you.
Thank you.